Okay, let's see what we've got here. My name is Vince Trevecki, and I am going to be taking us through three different microbes: Salmonella or Salmonellosis, fibrosis, and the bubonic plague. And really, Um, I chose these three because um, I really like the bubonic plague, and it's just something that really interests me. Um, So yeah, so here we go. Let's talk about salmonella first. All right. So what I got here is just a picture of salmonella, um, and you can see the flagella, the long kind of strings hanging off, and then the smaller pili, which are the little furs, if you will. Um, so um, salmonella is a bacteria, right? Or it comes from bacteria. It's a causative agent, and the it's an enteric bacterial pathogen, so an enteric bacterial pathogen, right? With is enteric bacilli, and we've studied a lot about bacilli and sort of what that looks like, and in the lab. So um, you can kind of start wrapping your head around what it is and what it looks like. Okay? It is a primary member of the Enterobacteriaceae family, um, and it's gram negative, non-sporing, and it is a facultative anaerobe. So um, it survives in a host cell. All right. So moving on with the causative agents, it's responsible for both food and waterborne illnesses. We talked a little bit about this in the earlier chapters, in some of the labs where we were, and lecture where we were discussing salmonella outbreaks and E. coli outbreaks and different things of that nature. Um, it can range from gastroenteritis, so just really bad stomach cramps and vomiting, all the way up to typhoid fever. And it's primarily found in vertebrate intestines, so humans and animals. And it lives in the host stool primarily. Okay, so continue on with the causative agent of salmonella. Um, its most common methods of induction are through like raw meat, poultry, or seafood. So you often can think about it like handling raw meat, right? I know my wife always talks to me about, um, you know, you touch raw meat, now you got to wash your hands before you touch anything else, and she's always um, very aware of if I leave food thawing too long, if I don't thaw it in the refrigerator, stuff like that. So things that can breed that bacteria and and breed salmonella. So uh, another way that people come in contact with salmonella a lot and can get sick from it is from handling food directly after using the toilet or changing a diaper. So as I mentioned earlier, salmonella um, lives in the host stool, and so you can imagine that using the bathroom or changing a baby's diaper um, where you're handling stool, or you could expose yourself to stool. You could easily transfer this onto food and then consume it into your body, and then you're in a world of hurt. And then also, so traveling to other countries can be increase your risk of getting salmonella, especially in developing countries. And that's where you're going to find most of the salmonella that results in typhoid fever. So salmonella typhi, um, and we'll talk a little bit more about that as we continue on through this. And then also, you got birds and reptiles are particularly known for carrying salmonella. Um, Gosh, I mean, the more and more we talk about it, birds are just dirty, dirty creatures, and reptiles tend to have it as well. Um, and so I saw a lot, and I found a lot of research surrounding turtles. So people who have turtles as pets, or like baby turtles in classrooms, and then young kids will go and put their hands in their mouth, and they can get exposed to salmonella that way. I attached another picture here of salmonella. And as you notice, like I was saying earlier, The things that look like strings or strings that would hold onto a balloon or little tentacle arms, those are the flagella. And then some present with fimbriae or pili, which as I understand it, are sort of look like the little fur that's growing on it. And then some will present as capsules, sort of like you're seeing here. Very similar to the way you would see a capsule in an antibiotic or some type of medication you were taking or herbal supplement. And these differences are very important to help identify the virulence differences and the determinants. So help identify one strand from another or one bacteria from another. So I should mention that Salmonella can be found in a variety of different hosts, so vertebrates, invertebrates, and higher plant forms. But the ones of medical importance, those ones are also found in the lower GI tract of humans and animals. So when we talk about the mechanism of action, and so when we're talking about mechanism of action, we're talking about how does that Salmonella make us sick and get inside our body and spread and infect us. And so they tend to colonize in the intestinal epithelium, and they trigger their own phagocytosis, which is a pretty cool concept. And I want to talk a little bit more. We're going to talk more about phagocytosis throughout this presentation, because it's a common theme across all three of my microbes. And so phagocytosis, the definition of that is the ingestion of bacteria or other material by phagocytes and amnioboid protozoans. And so just want you to continue to think about it. I know we've talked about phagocytosis throughout the lecture in the lab, and so I just want you guys to continue to keep in the back of your mind, phagocytosis. And so from there, they release an effector protein, and what it does is it injects itself into the host cell's cytoplasm, and then it causes this sort of like reorganization of the host actin cytoskeleton. I was reading and researching about this. It said dramatic, but kind of in my mind, I think of it more as like violent, and that it's just sort of like pushing its way in, and just I think about like a burglar who's coming into a house and trying to get in and out as quickly as possible, right? Like he's kicking in through the door, he's rapidly moving things around, he's pulling stuff off shelves, trying to find the most valuable stuff as quickly as possible to get in and get out as quick as possible and do as much damage as possible. And so this results in the attached bacteria just becoming engulfed, right, by that cell, and then from there it just spreads and makes us sicker and sicker. So here is a slide. It's just a picture of basically how Salmonella gets its method of action, basically. And I want to point out, I want you guys to notice, if you can, on this slide, right down it says the use of T3SS, and you're gonna see more of those in a little bit as we continue to talk through my different topics. But just kind of keep that in the back of your mind, because it will become relevant again as I talk about some of the other things, especially in bubonic plague. We'll talk about it a little more, and it's just a way, essentially, that that these bacteria, these bacteria kind of get in and cause some trouble within the host cells, and it stands for type 3 secretion apparatus, or and essentially what it is it generates these effector proteins, and and then they have a pretty negative effect. And, I'll get into a little bit more on bubonic plague, like I said, but I just want you guys to I just wanted to point that out. Okay, so let's talk about the symptoms of salmonella and what that looks like. So one of the big symptoms you'll have is nausea. You get a lot of vomiting, abdominal cramps, diarrhea, fever, chills, headache, and you can have blood in your stool. And what a lot of this comes down to is you can see much of this can lead to dehydration. So that's a major issue surrounding salmonella poisoning is dehydration. We'll talk a little bit more about that as we continue to go through this. Continuing on, the symptoms typically last 2 to 7 days. They can last up to 10 days. And it actually may take months for the bowels to completely return to normal. So you can imagine if you're having diarrhea and you're dehydrated and you're having these cramps and there's all of this phagocytosis going on in your stomach, it's just kind of miserable and terrible. And so this is again where that analogy of the burglar coming in through the house and just destroying things. I mean, salmonella is just this violent, kind of miserable, but rather short encounter. And then specific strands. So specifically, again, we're talking about some of the specific strands that can cause things like typhoid fever, and that would be the Salmonella typhi that I mentioned earlier. Okay, and so moving on with the symptoms, we'll talk about some of the special circumstances that can lead to worse or more impacted or more affected populations by salmonella. Again, these are going to be ways that you can increase your risk factor and or potentially be more affected by salmonella. And so one of the ways is international travel. With undeveloped countries, we have different sanitation processes, or their sanitation processes haven't evolved, and there's just more exposure to salmonella as you're traveling internationally. Again, like I said, owning pet birds or reptiles, they're dirtier and they're known to carry salmonella. So I'm not saying obviously don't have a pet or don't have a pet bird or a pet turtle. I mean, I had a pet turtle when I was, I don't know, 8, 9 years old, and it didn't result in me dying by any sense of the imagination, but it definitely did. Thinking back to it, I was like, I don't think I was very clean. Actually, I think the turtle actually died because we didn't clean his cage enough. So I can only imagine how dirty he was. Okay, so moving on. One of the things that can lead to the increased risk for salmonella is the overuse of antacids, and this is because there's acid in the stomach that can actually help kill and control the bacteria. But if you're overusing antacids, it beats down those acids, and then you're a little bit more susceptible. If you have inflammatory bowel disease, and if you recently used antibiotics. And so you'll see kind of throughout my presentation here today that there are several, so when I talk about bubonic plague and when I talk about fibrosis, two of the big treatments are the use of antibiotics. And in fibrosis, specifically cystic fibrosis, which I'm going to talk a lot about, is the use of antacids. And so it's just very interesting to me that these two can make you much more susceptible to salmonella poisoning if you're not careful. So, they sort of, in my opinion, build on one another. Okay, continue on with special circumstances, right? There are various types of immune problems that can also leave patients, particularly vulnerable. So, obviously, if you're immunocompromised, like having HIV or AIDS, sickle cell anemia, malaria, if you're taking anti-rejection drugs because of an organ transplant, And again, I'll tie that back into fibrosis as well, specifically cystic fibrosis. One of the treatments is a lung transplant. So you can imagine if, like worst case scenario, you're HIV positive and you get a lung transplant, because of whatever reason or because you had cystic fibrosis, and how susceptible you could be to salmonella. So it's really important to practice those harm reduction techniques of making sure you wash your hands and do things like that. And then if you're taking corticosteroids, right, and those can be for a host of different things. Okay, so salmonella. And how do you diagnose salmonella? Well, because we know that it lives in the stool, one of the biggest ways to diagnose salmonella is with a stool sample. You can also do a blood test, and again, like I said, a stool sample. So the epidemiology behind salmonella and salmonella outbreaks, 1 in 4 of the key global causes of diarrhea is salmonella. The CDC estimates that about 1.2 million people are infected with salmonella each year, and over 23,000 of those result in hospitalization. About 450 a year result in death, so that's a 2.6% mortality rate. Okay, so how do you treat salmonella? All right, so the treatment of salmonella, there's a couple of different ways that we can go about this. Right? Like I said earlier, the major concern with salmonella is dehydration. And one thing that stood out to me is that the symptoms typically pass before people make it into the doctor. Right? And so if you're at home and you're taking care of yourself, or you're experiencing some of the symptoms that I mentioned earlier, it's very important to not let yourself get dehydrated, so taking in plenty of fluids. There are medications that will combat salmonella symptoms, so antidiarrheals and antibiotics. One of them being loperamide or Imodium. And then another thing that I thought was really, really interesting and stood out pretty well to me was that antibiotics are only to be used in extreme and severe cases when the person is either immunocompromised or it's an extremely bad hospitalized case. So I would imagine this would be high-risk populations, so children and the elderly, and again, like I said, those who are immunocompromised, or like someone who had sickle cell. Because antibiotics can extend the amount of time that you carry the bacteria, and that can make you contagious or expose it to other people. And then it also puts you at an increased risk for relapse. So, for the most part, salmonella is going to run its course, and if you stay hydrated, it seems like you can come out of it pretty okay, as long as you're not a special population. Some of the home remedies, when we're talking about treatment of salmonella, there's things like taking in plenty of fluids. For adults, chewing and eating on ice chips, even though you may not be feeling well, your stomach's bothering you. And then in children, things that are going to be rehydrating, so like Pedialyte. Okay, so again, this was the talk about salmonella, and one of the things I want to mention as I close out salmonella is that washing your hands thoroughly before and after handling food is extremely important. So making sure that if you're handling raw meat, you're washing your hands before you handle the raw meat. You then handle the meat, then wash your hands again, and whatever surfaces you were using before you go and start handling vegetables or whatnot if you're cooking. If you are using the toilet or you're changing a diaper, make sure that you're washing your hands before you are cooking or ingesting food, putting it inside your mouth. And then same thing goes with if you're handling reptiles or birds or pets of that nature, right? Making sure that you're washing your hands thoroughly after you're handling them. Not eating raw or undercooked meat, poultry, or seafood. is also going to be helpful to prevent against salmonella. Taking special care when you're traveling overseas, being aware of your personal hygiene, being aware of the things that you're putting in your mouth, and doing your best to keep your hands free of microbes. Again, washing hands after handling bird or reptile pets, and then seeking medical care if the symptoms present, and staying hydrated. And so, as we close up and we finish up salmonella, I just want to remind you that, like I was saying earlier, you can actually not even realize. I mean, a lot of these symptoms are presenting like the flu, so you may not even realize that you have salmonella poisoning. But if you do believe that you have salmonella poisoning, go and seek that care and do everything you can to stay hydrated. All right, so we are going to move on to fibrosis. Okay, so fibrosis. Well, let's start with the definition of fibrosis, right? And so fibrosis is the thickening or scarring of connective tissue resulting in injury. There are a couple common types of fibrosis. There's cystic, pulmonary, retroperitoneal, and mediastinal fibrosis. So with my presentation, obviously there are a lot of different types of fibrosis, and so it didn't exactly give me too much of a straight guideline on how to go about, and so I picked the one that stood out the most to me and that I have some experience with. A guy that I went to high school with had cystic fibrosis, and so a lot of this presentation is going to be focused around cystic fibrosis, but just understanding that there are multiple forms of fibrosis, and that fibrosis in general is a thickening or scarring of connective tissue resulting in injury. All right. So for cystic fibrosis, it's a genetic disease, so it is going to be hereditary, and it results in a deficit or a defect of the transepithelial C1. This is a mutation of the cystic fibrosis gene, and it can be found on chromosome 7. And basically what it does is it codes for CFTR, and we'll talk about what CFTR is. And its most serious symptom occurs in the lungs. So, and you'll see how a lot of that shapes up as we move forward. Cystic fibrosis puts you at an increased risk for various bacterial infections as well, and it's going to be caused by the extra mucus that just makes these happy little homes for bacteria to live in. Okay, so the causative agent, again, this is focusing on cystic fibrosis. So if you're 0 to 10 years old, right, the main causative agent or the major player is going to be Staphylococcus aureus. So MRSA. Right. Then you also have Haemophilus influenza. And in the second and third decades of your life, so 20 and 30s, adults basically, so you're looking at Pseudomonas aeruginosa. And so those are some of the causative agents that will be present in cystic fibrosis. There are major pathogens. There's some more major pathogens that are involved with cystic fibrosis, and I've listed some of those here. So NTM, so non-tuberculosis mycobacteria, and it's one of the most common types of non-tuberculosis mycobacteria. There's Microbacterium abscus, Microbacterium avium, Mycobacterium intracerellae. Okay, so let's go into the mechanism action here. And I didn't spend a ton of time on the major pathogens. There's a lot of them, and there's also a lot of minor pathogens that are involved. So and just basically understand when you start to understand the mechanism of action, what actually happens with cystic fibrosis, it'll make more sense as to um, why there are so many pathogens that are involved in cystic fibrosis and why it's you know one of the major issues is persistent and consistent lung infections. Okay, um, so cystic fibrosis deals with a conductance regulator. So the CFTR is a cystic fibrosis conductance regulator. And essentially, what happens when this gets disrupted is there's misfolded or improperly functioning CFTR. Right? And the CFTR is pretty cool. What it actually does and how it all comes together. Okay, so its area of operation is the apical membrane of the epithelial cells of organs. All right, so it's the apical membrane right there, just sort of like um, right on that surface of the cell. And so it's a chloride ion channel, and essentially what happens is that chloride ion channel, if you remember from chemistry or anatomy and physiology, that chloride channel lets chloride out of the cell and sodium into the cell, and then you see water typically rush out of the cell, right? And so what this water rushing out of the cell does is there's like a clearing, right? It thins mucus out and it keeps everything kind of smooth, right? Water is a nice lubricant and it just keeps everything flowing well, okay? Um, but when we have dysfunction or a mutation of the CFTR, that channel gets restricted and it restricts the flow of water. Right? So this then goes and thickens the mucus because it's not able to clear it all off, and we run into sort of this buildup, if you will, of mucus, and it just starts to compile, right? If you can imagine, I think of it sort of like um, you know um, that water acting sort of like when there's a big snow, right? It's like the snowblower goes out there and blows all the snow off, but when that's not working, your snowblower is not working, it can't get rid of that mucus, so it just starts piling right on top of itself, and 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 it really starts to mess things up. So and um, it'll end up disrupting that ciliary clearance, like I was talking about, basically that snowblower. Okay, and so when that mucus is set there, it's creating that happy home for those microbes to grow. So that's why there's so many major and minor pathogens that can be involved in cystic fibrosis, because there are it's just this breeding ground, right? This mucus that's just creating these pockets and these homes for these microbes to just flourish, which can then lead to chronic pulmonary infections, inflammation in the tissue, and diminished lung function. And this is where that cystic fibrosis, right, that damage of the connective tissue of the lungs comes in. Okay, so going on with the mechanism of action, and as I kind of explained this, I used to work. I used to work for a company that managed all of the security for a major UPS hub, and so all of the employees coming in and out were um, the employees coming in had to go through one gate, and the employees coming out had to go through another gate, and then there was a difference. You could tell who were the drivers because they wore the brown UPS uniforms, and then there were the package handlers who were just wearing normal whatever work clothes like jeans and t-shirts and hoodies and stuff like that. But there was a clear difference in who they were, and then there was a clear difference in like who went in and who went out, and all of that was controlled by a gate. And the reason that I say all of that is I want you to kind of keep that in mind as we go through more of the mechanism of action surrounding cystic fibrosis and the CFTR. Um, okay, so the CFTR is going to create that. It's a protein pathway. It's basically the gate that I was talking about, right? And so what it does is it sets and it opens and closes so that sodium, it creates that sodium channel so the chloride can come in, the sodium goes out, the water goes out. It, it has a ciliary clearance and whatnot. So that's how it's supposed to work, right? Um, the, the chloride, so the guys and the UPS drivers in their brown uniforms, they come in, and then the package handlers, they're going out, right? So there goes the chloride, or excuse me, the sodium, and then um, we have um, the CFTR, which is this gate. It's just letting things go in and out, all right, and it works, and everything is good, okay. Um, and that chloride channel, it's a ABC transporter made up of three parts. And so when we talk about that, right, that may not completely make sense, right? And we're getting kind of deep into the into what actually is um, the mechanism of action when we start talking about the cystic fibrosis um, here. And so um, that ABC, right, and let me just double check because I want to make sure that I tell you exactly what it is. Um, it it is again it's keeping that transporter, and it's going to help with ATP and the energy and what we need here in a little bit. And I'll explain that here a little more. And so there are um, a couple of different parts to this, right? Um, and let me just make sure that I have all this here, because I want to make sure that I don't speak out of turn. Right? Okay, so that ABC, it's a excuse me, um, it's an ATP binding cassette transporter, right? And it has three various specific kind of parts to that, right? So within that, there are two nucleotide binding domains, so NBD1 and 2, and then there are two membrane spanning domains, so MSD 1 and 2, and then there's a regulatory domain, so the R domain, right? And so that's where we get the NBD, right? So the nucleotide binding domains, right? And the MSD, right? The two membrane spanning domains, and then finally we have the R domain. So that's that regulatory domain. All right, and so that goes back to talking about the chloride channel as being an ATP binding cassette transporter. Okay, so um, what do the NBDs do? Well, the NBDs, they are going to bind the ATP. So essentially, they're holding the energy. They're grabbing the ATP so that channel has the ability to open and close. So if you can think of it, kind of like the power source to the gate, right? If the power were to go out and the gate doesn't open or close, the drivers can't get out, so the chloride can't come in, the sodium can't get out, and so we have sort of this blockage, right? So that NBD is going to bind that ATP, right? And then the MSDs are like anchors. So we think what those anchors do is um, they're going to keep everything in place, right? They're going to make sure that channel stays right on the surface of the cell and that it does exactly what it's supposed to do. So I kind of think of them as like the walls, right, if you will, or the anchor points that so if like people wanted to try and move, something out of the way, like they can't. That MSD is gonna they're gonna bind that channel in place, right? And then we have the R domain, and that's the gatekeeper, right? So that's the security guard who is making letting everyone in, letting everyone out, and just regulating the control of that, right? So, okay, so moving on, we talk about the mutation of the CFTR on chromosome 7 and how this impacts sort of the above areas of operation. So everybody's got their role, okay? And then we have this mutation of the CFTR on chromosome 7, and everything gets out of whack. And this next picture is going to kind of show you a little bit about that, right? So on the left side, it shows you sort of like your normal CFTR channel, right? You've got your, you got your package handlers going out. You got the drivers coming in. So the sodium and the chloride and the water is moving around. Everything's great. And then if you look over on the right side, when things are all jacked up and that CFTR mutation happens, then that mucus starts to build up, right? And so there's this blockage, right? If no one can get in, no one can get out. Here's the chloride ions down at the bottom, and they're wanting to get out. They want to go home, and then here's this mucus. Here's these, this brown gunky, these these UPS drivers that want to get in um, and and get going, but they can't, right? So it's just packing on the outside of the cell, and that's sort of the like a little analogy that I kind of came up with, or the vision in my mind when I think of this CFTR um, mutation, right, and how this mechanism of action works. Okay, so what are the symptoms of fibrosis, specifically cystic fibrosis? So it's going to impact your respiratory, digestive, and reproductive systems. You're going to have persistent cough with thick mucus. You can imagine why. There's wheezing, there's breathlessness, increased lung infections, and frequent stuffy noses, resulting in frequent sinus infections, bronchitis, and pneumonia. And again, this stemming from the fact that there's all of this mucus because there's not the ciliary clearing that's going on because the water can't get out because the CFTR channel is all jacked up, right? And there's this mutation that's not doing its job. And so all of this, all these microbes, all this bacteria is just growing and living and thriving and just messing everything up. Okay. Some other symptoms, you can have foul smelling or greasy stool as it starts to infect your digestive system. You'll have the inability to gain weight, and really what ends up happening is there's a lot of intestinal blockage. There's a lot of issues surrounding the digestive tract and your nutrition, your ability to maintain adequate nutrition. There's intestinal blockages, and this is primarily seen in newborns. Severe constipation and infertility in men specifically. Some of the complications that we see are respiratory issues, right? Damaged airways, right? Fibrosis being, right? Um, connective tissue damage. Chronic infections, again, coming from all the bacteria that's living in all of those, the happy home mucus. Right? Pneumothorax, so that's going to be where air is filling up some of that space inside the chest cavity. Right? You have digestive issues, nutritional deficiencies. It can result in diabetes and a blocked bile duct. So, these are all just really tough things to have to deal with, right? And so, it's cystic fibrosis is really, really a really tough disease to have to go through, right? Fibrosis in general is difficult, but definitely you can see that this is presenting with, just it can attack a lot of different systems. And why is it attacking those systems, right? Well, primarily because of the fact that there is all of this mucus and that all of these microbes can hang out and they can um, they can just thrive, right, in all of these different environments, right, and they can start affecting all of these different systems. And, oh man, it's just really, really, really rough. Okay, so moving on. All right, we also have reproductive issues like we talked about earlier. In men, there will be a lot of infertility. Some of the other complications that you can run into would be like osteoporosis, and that can be from the poor nutrition and dehydration as well. All right, so how do you get diagnosed with cystic fibrosis or fibrosis in general? Okay, So every state in the United States screens for cystic fibrosis now, and they do it right at birth. Um, there can be a blood test looking for an elevated IRT, right? Um, and so, essentially, you're looking for your immunoreactive trypsinogen, uh, trypsinogen. It's immunoreactive trypsinogen, or IRT, and that's released by the pancreas, and they can see that in the blood. But that can also be raised if there was premature birth or a stressful birth. So there may be other tests that need to be done to confirm. And so you can do a gene test, so they can test specifically for the gene that um, that is on chromosome 7, and then they can also do a sweat test. And these sweat tests is they're going to go ahead and they're going to put um, like a chemical on the skin, if you will, or it's like a sweat-producing chemical, and then just put it on a small area of the skin, and they're going to test that sweat to see if it's saltier than normal, right? And that may have to be done specifically at a cystic fibrosis testing center. Older children or adults who believe they may not have been screened um, can get gene tests or a sweat test done as well. So when we look at the epidemiology of cystic fibrosis specifically, um, since it is a genetic disease, you have to have 2 copies of the defective gene and 1 from each parent. Right? So 1 copy, if you just have 1 copy, you'll be a carrier, but you won't necessarily have cystic fibrosis. If you have 2 carriers who have children, so if I was a carrier and my wife was a carrier and we had kids, there is a 25% chance that our child would have cystic fibrosis. There's a 50% chance that they would be a carrier but not have cystic fibrosis, and there's a 25% chance they wouldn't be a carrier or wouldn't have cystic fibrosis. So that's really kind of interesting odds. Worldwide, there's about 75 or 70,000 people who are diagnosed with cystic fibrosis. Approximately 1,000. There's 1,000 new cases diagnosed each year. 75% of those are diagnosed by age 2, and a lot of that has to do with the fact that it's pretty much standard practice to test for cystic fibrosis right from birth. And then 50% of the people living with cystic fibrosis are adults, and what that's basically saying is that the treatment has gotten to the point where you can have a fairly decent quality of life. So speaking of treatment, there isn't a cure for cystic fibrosis, and is a bit complex. It definitely requires specialists. The goals are preventing lung infections, loosening the mucus, preventing intestinal blockage, and maintaining adequate nutrition. This can be done through medication such as antibiotics, anti-inflammatories, mucus thinning drugs to improve lung function, so that ciliary clearance, right? Bronchodilators, ingested, so basically oral pancreatic enzymes, right? And things like Invocraftor, which will improve lung function, weight, and the salt sweat reduction. So it's trying to help keep you a little less salty, if you will, right? And that's FDA approved. And then you also have like Orkambi, which is approved for 12 or older, and it's basically for certain mutations of the chromosome 7 or the CFTR, and that combines Imbocraftor and Lumocraftor together. Okay, so the other types of treatments, and I guess these are more like treatment based than they are medication based. But you have chest physical therapy, so to try and loosen some of the mucus in the chest. There's vest therapy, so you're wearing a vest that's going to vibrate and try and loosen up some of that mucus. There's pulmonary rehabilitation, nasal polyp removal, oxygen therapy, endoscopy and lavage. You can get feeding tubes if you're not able to maintain your nutrition. Right? You can get a lung transplant. and continuing on, there's also like clinical trials that are being run a lot, and there are also various home remedies and harm reduction techniques that you can use. So the harm reduction techniques, right? When we're talking about just trying to minimize some of the symptoms, exercise, adequate nutrition and hydration, up-to-date immunizations, eliminate smoke exposure and smoking, and then minimizing your exposure to bacteria. Again, remembering that there's that mucus that can just trap that bacteria and it just lives and thrives. So, in conclusion on fibrosis, specifically cystic fibrosis, there's multiple types, right? And so they can be pulmonary, it can be cystic, it can be sort of some of those other types that we talked about earlier. There's a defect on the CFTR protein. There's an excess mucus buildup due to the inhibited ciliary clearing that we talked about from the CFTR channel not working properly. That mucus buildup creates a happy home for bacteria to live. Things like MRSA, staph, and Haemophilus influenza. Really is hard on the lungs and the digestive system. It can also be hard on the reproductive system for men. Early detection and aggressive treatment are the best courses of action, and all children are screened at birth in the U.S. And so medication, lifestyle changes, clinical trials are all various types of treatments that are found to be pretty effective in the symptom management of cystic fibrosis because there is no cure yet. Okay, so we're going to move on to the bubonic plague, and this is what I've sort of been waiting for. Unfortunately, it was actually my shortest because there was just there was information about it, but we've managed it really well over the years. Okay, so bubonic plague. What's the causative agent? Yersinia pestis, right? And it's gram-negative. Right? It's nodal. It's a rod-shaped coccicillus. It has no spores. It's an enzootic vector-borne disease. Right? It infects rats, and essentially it then infects fleas because the fleas get on the infected rats, and other rodents bite them and then carry it. And then that's how it's transferred to humans, is by flea bites. And it's pretty much thought to have originated in Asia and then transferred west via the trade routes. Okay. So, as we continue to look at the bubonic plague, here's a picture of what it looks like under a microscope. And like I said, its domain is bacteria. Its phylum is Proteobacteria. The class is Grammoproteobacteria. The order, Enterobacterialis. Family is Yesinacea. I really can't say that word. I've tried so much. Google can't say it either. And the genus is Yersinia, and then the species is Y. pestis. Okay, so the mechanism of action. So what happens when this microbe gets inside your body? All right, so it's a facultative intracellular bacteria, and it's going to invade the host cell, preventing phagocytosis, right? So we talked about phagocytosis a little earlier, and it works on it basically prevents the host cell from being able to eat the bacteria. Right? It produces a virulence plasmid, and that encodes the T3 SSs, right? And so that's what we were talking about earlier, if you guys remember, where I was talking about how it was going to be talked about a little bit more within some of my other presentations. Well, here we go, and we're going to talk a little more in depth about it. Now, if you remember when I was talking about salmonella, right? Or excuse me, fibrosis, like how sort of that was working. Um, we're going to go, like I said, much more in depth into what actually happens here with these when we talk about bubonic plague, and it's actually pretty interesting. So what it does is that T3SS, so the type 3 secretion system, okay, um, it it's going to secrete these YOP protein substrates. And so it kind of gets in there and it encodes this, this type 3 secretion system, and it takes these 6 YOP proteins. And what they end up doing is they go in those proteins and they inhibit the phagocytosis and block the pro-inflammatory signals that the cell would send to fix itself. And so, I mean, that's just, to me, it's just really kind of cool the way that it works, right? You've got this T3SS, this type 3 secretion system, that comes in here. This bacteria has this, I guess, this virulence plasmid, right? And it's going to get in there and it codes this T3SS onto the cell itself, and then these proteins get in there and they completely it's like a hacker to me, right? They completely rewire what the cell's doing to itself. Right? So when we come and we talk about some of the symptoms of bubonic plague, on the right there's a picture of buboes, right? Or buboes, and that is a good way to tell if you have bubonic plague. It's pretty clear, but it's swollen lymph nodes that you're going to see about the size of a chicken egg, so you can see them pretty big there. Right? They're tender to touch. You'll find them in the groin, armpit, and neck region. You can also, some of the symptoms being onset of sudden fever or chills, right, and fatigue. You also have some muscle aches. Okay, so how do you test for bubonic plague, right? What's the diagnosis? Well, for bubonic plague, there's actually, for plague in general, there's 3 types of plague, right? So there's bubonic plague, there's septimetic plague, and there is pneumatic plague, so pneumonia plague, basically. And for bubonic plague, your test or your diagnosis is a fluid sample from the buboes itself, right? There's a blood test for septicemic plague, and then there's a sputum or a fluid test for pneumonic plague. Attached here, this picture that I have is just kind of an idea of where you see plague at. And the reason I picked this picture, is because you can see the state of Colorado, and there's a big red line kind of down the middle of it. And so in Pueblo, Colorado, there's a large population of prairie dogs, and that's about 2 hours south of where I live, that carry bubonic plague. So the epidemiology behind this, right? It started with the Philistines. That's the first thing that's noted and that's made it through history, back in 1320 BC, called the Justinian plague of the 6th century, where about 10 million people died of plague. In 1347 to 1350, you've got the Black Death, which has got accumulated about 50 million deaths, about 60% of the population of Europe. I read that there were whole towns that didn't survive, and other places there were not enough people who survived to be able to clear the dead. So it was about half of the 50,000 came from Africa and Asia, and the other half came from Europe. And then the modern plague from 1860 to 1894 killed about 10 million people, and that was through Asia again. After the causative agent was identified, though, we were able to control it pretty well. It did rear its head in India and the Vietnam War in the 1960s and 70s, and that's because it was weaponized. And it's most commonly today found in sub-Saharan Africa and in Madagascar. About 95% of the cases come from there today. So treatment for bubonic plague. Once we identified the causative agent, the treatment became relatively manageable, and it was done basically with powerful antibiotics. Some of those being um, uh, gentamicin, sorry, doxycycline, um, ciprofloxacin, so Cipro, and levofloxacin. Okay, so I attach these pictures here because um, they're really cool pictures. The thing that I like so much about the plague were the plague doctor masks, and so I'm going a little bit over on time here, but I'm going to talk about this anyway. Um, a lot of times when you see people talk about the plague, you see them wearing these masks, right? These leather hoods that had these beaks on them, and they're very intimidating, very scary looking things, and so all of these plague doctors would wear these masks when they went around, and there was this huge stigma around the plague. Um, but here's the thing: a lot of people don't understand what was going on with that. What it was is the stench was so bad from the plague that what they would do is they'd take these masks and they'd stuff potpourri or debris down in the beak so that they could mask the smell, right? And this was just the early invention that they had. And then they would cover themselves, obviously, in leather and as much as they could to protect themselves because they couldn't figure out how it was spreading at the time. Um, and the other thing about plague doctors was a lot of people think that plague doctors were these doctors who were doing these great things out in the world, but they were typically doctors who were very low. They barely graduated medical school. They were the lowest in their class, or they had failing practices, and the towns and cities would hire them to come in because nobody else wanted to go and do this. So they weren't the best doctors in the world. Okay, so to close out bubonic plague, so it's caused by the bacteria Yersinia pestis. It invades the host cell and prevents phagocytosis, and that's through those T3SSs that are going to bring those YOP proteins, those sick YOP proteins that prevent the phagocytosis. So it's type 3 secretion system. It's spread by rats, mice, squirrels, and prairie dogs. Fleas bite the infected rodent and then bite humans. And so since there's, we talked about these three types of plague, pneumonic plague, the septic plague, and the bubonic plague. It's only passed through the fleas at first, right? And so if you have bubonic plague, you're not going to pass it on to somebody else. But when it comes to pneumonic plague and it turns into pneumonia, then you can start making it airborne, or the liquid that you cough out, then you can pass it that way. Again, there's three types of plague: bubonic, septicemic, and pneumonic. Transmitted by flea bite until it turns pneumonic. And the Black Death plague, right? Remember, it was responsible for the decimation of 60% of Europe's population in the 1300s. It can be weaponized with terrorism becoming so much more prevalent since early 2000s. It's been a big concern of the United Nations and the United States about if terrorists would try to weaponize plague. And it was weaponized back in the 1300s as well in some of the other plagues where they would throw the dead bodies over the village walls to use as a weapon. And then in modern day, so today the survivor rate's very high thanks to antibiotics. So that's all I have for you. I've got all of my references there. If you have any questions about this, please feel free to shoot me an email. And thanks for listening.